The new health program under the Affordable Care Act that is designed to offer the public many benefits. What is the program? We'll discuss it on Talking with Henrietta, coming up next. Hi, I'm Henrietta. Welcome to the show. There is a new program being rolled out that will enable thousands, perhaps hundreds of thousands, to qualify for both Medicare and Medi-Cal. The program is called MediConnect, and it combines both Medicare and Medi-Cal. This new medical program is launching in counties throughout the state of California. Those who qualify for both programs are called dual eligible. On this show, I have 4 guests with me who will discuss what the program is, the benefits it offers, who is qualified, and how people can apply. On my far left is Maya Altman, the Chief Executive Officer of the Health Plan of San Mateo. Before joining the Health Plan of San Mateo, Maya served as the Director of Finance and Administration for the San Mateo County Health Department. Beside her is Thong, who is a community advocate for the Vietnamese community in Santa Clara County, and he is a caregiver for both his father and his mother-in-law. To my immediate right is Tony Solem, who is the Chief Medicare Officer for Santa Clara Family Health Plan, where he oversees all aspects of the MediConnect program. Tony has over 22 years of managed care experience, having successfully expanded Medicare programs in Arizona, New Mexico, and Texas as Executive Director for United Healthcare Group. Shelly Grimaldi is an outreach coordinator for MediConnect for Northern California. She is a San Francisco native who studied public health at UC Berkeley. Well, thank you so much for joining me. It's a pleasure having you here. MediConnect sounds like a very complicated program. So why was Medicare and Medi-Cal combined?
Well, I think it's important first to define what Medicare is, explain what Medicare is, and what Medi-Cal is. So Medicare is a program for people who are 65 or older, or people with severe disabilities under the age of 65. Medi-Cal is a program for people who have low incomes. So the people that are eligible for MediConnect, by definition, have a lot of challenges to face navigating both programs. Many of them are much sicker or have more problems than people in the general Medicare program or the general population. They're people with dementia. They're people who live in nursing homes. They may be homeless. They're people with mental illness. So it's really important to make it as easy as possible to navigate the healthcare system and give them the best possible healthcare services for a particularly vulnerable population.
And you think this program does that? It makes it easy for people?
It will. One of the things is that with so many different aspects of the programs, people often, they had their Medicare plan, they had their Medicaid plan. In California, they had a number of different services that were provided through county and local agencies. So while people are currently have been comfortable in a sense with all those different aspects and avenues, one of the goals of this program is to bring it all under one program so a person has a single card. It should be easier and simpler in that sense for the member. Certainly the care is the most important, and the care has a much higher chance of being better coordinated for the members. And it should also be simpler for the providers as well, because they'll be dealing with one agency rather than multiple agencies.
Well, it sounds good on the surface that the two programs combined would streamline everything and, as the two of you said, combine two programs and make it simpler. People have an option to opt in or to opt out. Is that true?
That's right.
a lot of people are opting out. So if it's that simple and it makes it better, why are people opting out?
Well, I think one of the things, again, is that it's different. So anytime that you have a change, then not everybody wants to change at the same time at that moment. So some of it is just getting used to the program and understanding that it will take care of all of the same benefits that they've always had. It's just a different look. And so that's part of the reason why people would opt out. It is important that within the Medicare world, Medicare encourages options for folks and realizes that there isn't a single design that works for everybody. There's not a one-size-fits-all. And so within this population across the country, Medicare generally allows folks to make a change when they want to or they're ready to.
So
I'd
yes,
also
go
point
on.
out that in San Mateo County, we started our MediConnect program last April. We had an opt-out rate of 30%. That's not high. I mean, when you consider that 70% of the people stayed with us, 30% yes, they didn't want to see any change, they were scared, or they may have been seeing a doctor. For example, we don't contract with UCSF. If they're seeing doctors at UCSF, we said it's better for you to not be part of the program because we don't contract with them.
Sure, you're going to say something,
Oh,
Shelly.
I was just going to say that as an outreach coordinator, one of the things that I encounter frequently is people asking me, well, if MediConnect offers Medicare and Medi-Cal benefits, why is it any different than the benefits that I already have under those two programs? And what's sometimes difficult to describe to people is what that care coordination is going to look like and how it is significantly different than regular Medicare and Medi-Cal as they exist today. So every person who joins a MediConnect program is offered a health risk assessment, which is basically an interview about your health. This is the first time, potentially, that some people are being asked, what services are you using? What doctors are you seeing? What services might you need in the future? And just that initial interview alone could connect someone to services that they're not accessing right now, that they do have benefits under MediConnect, or under Medicare and Medi-Cal rather, that they're not using to full
No.
advantage.
Some people fear that they're going to lose their doctors. I know in the Filipino community, for example. So, do people have to lose their doctors?
No, they do not. First of all, the program has built in a 6-month continuity of care, it's called, so that they can stay with their doctor if the health plan doesn't contract with them. We make every effort to contract with the doctor. And if we can't, if we're unsuccessful, and the person really wants to stay with their doctor, they can opt out at any time. There's not a one-time opt-out period. They can opt out every month.
Oh, that's interesting.
Yes.
But they have to enroll if they're going to opt. Oh, so you're saying
Yeah, let's
at
say
any time along the
At
way.
any time during the year. I mean, you and I in our insurance plan, we only have an annual enrollment period, so we have to wait to that period to change plans. These folks have a right to change plans. They can't do it more than once a month, but every month they have an opportunity to change plans.
Sure. Thong, you were going to say something.
Yes, as a caregiver, I'm sure it's going to be benefit for myself and my dad and also my mother-in-law. The fact that the care coordination there is going to be provide doctor's appointment. It's going to be provide transportation for me, which is a lot of times, I have to take day off from work and just to drive them to the doctors or even making appointments for my folks, which is a very hard thing to do. And another thing, the reason why I have to make phone calls to make appointment is because of my schedule, the time availability for me to drive them to the doctor. So with the care coordination here, that Care MediConnect is going to provide, it's going to be a big benefit for my families.
Sure, and it's my understanding too that people can stay in their homes, that they can get services directly in their homes to their homes.
So there are already in place Medi-Cal long-term support and service programs which have been geared towards helping people who could be about ready to transition into skilled nursing facilities, but with a little bit more support to stay at home. And those Medi-Cal programs have been paid for by Medi-Cal as a program before, but under MediConnect, they're required to exchange more information with the health plan so that, for example, let's say someone is receiving 10 hours of in-home care, and for 5 years, 10 hours of in-home care a week is all they really need. But if there's communication between their primary care physician, their IHSS, their in-home caregiver, and their health plan. As that person grows into more needs and needing more hours, that can be a conversation that happens, so that people who otherwise would have to go into skilled nursing facility if they don't have that support program, you know, they go from 10 hours a week to 15 hours a week, and it's a transition that supports them staying where they want to live.
You
So
know, I'd
Shelly-
even go beyond that because
Sure.
as a health plan, we now have the ability to take some of the money that we've been spending on nursing home care, and we spend up to $150,000 a year for somebody to live in a nursing home. Some of these people do not need to live in a nursing home. They want to live in the community. We can now, under this program, we now have the flexibility to use that funding to pay for other kinds of services like in-home support, personal care workers, anything the person needs to be able to stay at home successfully and not have to live in a nursing home.
It's my understanding, too, that patients will have advocates to interface between them and their doctors or medical institutions. Is this something that's true?
That's what I believe, and they're going to be provide language and cultural appropriate to these needy population. So that's going to be another plus for me. Driving them to a doctor, help myself. I have to be physically in the doctor office to provide interpretation for my parents sometimes, depending who they need to see. If they need to see a specialist, usually those doctors are monolingual, English speaking only, so I have to physically be there, spend the time. And you know, and in medical terms too, there's a lot of times that I misunderstand or they used medical term language that I couldn't understand.
So you're saying that there's someone who would be there who speaks Vietnamese or...
to provide the cultural and the language appropriate to these
Do
folks.
you have
That's
to
what I understand, isn't it? Yes.
So the interface, the person that you're talking about is the care plan coordinator. And individuals who are found to be high risk, people who do have a lot of medical need and are not necessarily getting all the services that they could use right now, they're automatically assigned a case manager. That case manager in most cases is a nurse who's employed by their Cal MediConnect health plan. And it's that individual's responsibility to help them connect to language appropriate doctors, to help them set up a transportation benefit if that's what that patient needs to get to and from appointments. The case manager also serves as this important communication piece. For example, if a Cal MediConnect recipient or a Cal MediConnect beneficiary is hospitalized and then discharged to go home, that patient has new needs because they were just hospitalized. And so instead of having, you know, a couple of doctors that know that there's a hospitalization that's happened, you have a care plan coordinator that says, you were just hospitalized, you're not driving right now, we'll help you set up that transportation benefit to get to your follow-up appointments while you're recovering.
Now, is this all at extra cost?
Is it all at extra cost? Well, with the plans we're given, the way it's set up financially, we're given one rate. We're getting, well, two rates actually, one from Medicare and one from Medi-Cal. But it's our responsibility to make it work for the members. And what we're going to try to do is try to help keep people out of the hospital, which is very expensive, try to keep people out of nursing homes, and use that funding more wisely to, because all these things, you know, they add up. They may be little things, but they help keep people out of hospitals. So if somebody, people who are just discharged from a hospital are at the highest risk for being readmitted because they leave the hospital, you know, they heard all this information about medications, but they really don't understand what they're supposed to do. If they have a care coordinator who can help them go through their medications and make sure this is what you should be taking, this is what you should be doing, that goes a long way towards preventing them from going back into the hospital.
And
So
to
can I-
build up a little on what Maya said, is that we consider it an investment in a sense that there's work and time spent putting together this care team with the care coordinator and the member at the center of that. But it's certainly, it's at no cost to the member. The member doesn't pay anything for that service. So we build that team together, and then the benefits are there in terms of more efficient care, more effective care, and so you know, again, it's at no cost to the member, so we think it's a huge positive.
Sure. Thong?
So the care coordinator is going to make sure to remind those folks for their appointment, or are they whose responsibility? Not whose responsibility, but is that one of the coordinators is going to do, is to remind those folks, you have an appointment next week, Monday at 9 o'clock. Somebody by the name of so-and-so is going to pick you up at certain time, or what? Do you know what's going to be happen? Or my parents, you know, what they hate is when they call that number, 1-800 number, and, you know, press 1 for English, press 2 for Spanish, press 3 for Chinese, and 4 for Vietnamese. And I mean, if they know, if they understand that, they wouldn't ask me to make that appointment for them.
So Shelly,
do
you can answer his question. Will someone call and remind them?
So what that care coordinator does for the patient is going to depend on the patient's needs. Not all patients are going to need a call 2 days before their appointment to remind them. There are lots of patients who are still in a position to help manage and coordinate some of their own care. But it will be the coordinator's responsibility to make sure that the patient knows they have an appointment. When they're leaving one appointment and they've already scheduled a follow-up, that message needs to be made clear that there is a follow-up appointment that's already been scheduled. Something that I think is also sort of on the same line is that the interdisciplinary, or the care plan coordinator is coordinating between all of that patient's doctors on this thing called the interdisciplinary care team.
Okay.
All that means is that all the providers that are offering care for this patient are required to meet at least once a year, either by phone or in person. And why I bring that up now is if you, as a very involved caregiver for both your father and your mother-in-law, if they were to join MediConnect, there would be a place for you on that interdisciplinary care team, so that when they're having meetings about your mother-in-law's care, you're there to hear all the instructions that she needs. You're there to provide feedback about how she's been doing at home, because the information you bring from the home setting is just as valuable to her care plan as the information that her provider brings.
What about picking up prescription and dropping off the prescription for those folks? Because
Care plan coordinators can help work with that, yeah.
Okay, certainly it took a huge chunk amount of time for me to do that.
Mm-hmm.
So this is something that care coordinators can schedule?
So like I said, it'll be a conversation. If somebody is discharged and sent home and they're in a position where they're not going to be able to go and pick up prescriptions easily, you can think of a care plan coordinator as like your teammate in problem solving. They're not going to be the person that shows up at your door with the prescriptions necessarily, but they're going to do everything in their power to make sure that you have transportation to your pharmacy, the drugs are at the pharmacy on time, ready for you to pick up, or for your caregiver, or delivery if that's what you need as the patient. It's going to be, that's what's nice about the care coordinator, is that it makes it so that all these benefits that are being offered to a very wide population can be personalized to the needs of that one patient that they're working with at that time.
So let's talk about the plan in general. It's rolling out to 7 counties in California right now. And it's already rolled out to several of them, like San Mateo County.
Right.
Who's eligible for the program?
So you have to have Medicare, be eligible for Medicare, and
Which means you have to be over 65.
you can be under the age of 65 and have a severe disability that qualifies you for Medicare. So a lot of mentally ill people qualify for Medicare. And you have to have both Part A and Part B Medicare. That Part A is the hospital benefit, Part B is the doctor benefit. So you have to have both sides. And you have to be eligible for Medi-Cal. So you have to be low income. And that makes, for the most part, that makes you eligible. There are a few exceptions. So people with developmental disabilities are not eligible for the program right now. We're working on that, trying to change that. But for the most part, people that are Medicare and Medicaid eligible are eligible for this program.
So how are people notified about the program?
The state has sent out packages or notification letters. Currently, there's a program that's called passive enrollment. So there are certain members who are both eligible again for both Medicare, Medicaid. They get a letter from the state of California.
In a blue envelope. Right?
Yes, in a blue envelope, and tells them that they will be enrolled in this plan. And they generally will get at least a couple of notices, like 90 days and 60 days. And then the health plan sends out another notification to them. So they get it, informed about the program, and they have the opportunity to make that decision whether they want to stay in or opt out anytime up to their effective date and then beyond.
Other than it being a new program, many people, I understand, are very confused about it, that there is a big packet of information. So are there tips for how people can walk their way through this complexity of information?
Yes. Well, what I would suggest to people in San Mateo County is that they call us and we will explain the program to them. They can also call, I think it's true in both counties, they can call something called HICAP, which is a health insurance counseling program. And it specializes in Medicare, but they've been trained to help people through this program. So I think the best thing is to try to call somebody to walk through it with you, because it is very complicated.
And yes, Shelly, go on.
Oh, I was just going to say that, again, as an outreach coordinator, when I go to do presentations, it's my responsibility to explain these enrollment materials. And through our outreach strategy, what we've been doing is trying to target what we call frontliners. So people who are social workers, people who work in senior centers, people who are going to help people fill out these forms. Because there are seniors who potentially would be confused by the materials. The way the materials are structured, though, is it's supposed to make it an intuitive process. So there's the first letter, which tells you that you're eligible. Your second letter, which says if you do nothing, you will be enrolled into this program. And then the third letter, which says your coverage with Cal MediConnect begins in 30 days because you did nothing at that second notice. Or it'll say you chose not to enroll in this program, your Medicare is staying the way it is. And so that's the way those three notices work. At that second notice is when a packet comes that's called the guidebook, the Cal MediConnect guidebook. It's written to the 4th grade reading level, and it's intended to help someone who has never heard about this program ask themselves the basic questions about whether this is a good plan for them or not. So what we're expecting is that seniors will bring these guidebooks and these notices to their doctors, to their senior centers, to wherever it is that they get their advice. And that's why we've been targeting these frontline people who will probably be the recipients of those questions when those notices come in.
Well, the way Shelly explains it, it seems very clear. It seems like it's simple.
That's my job.
It's simply laid out. And yet there's a lot of confusion about it.
Yeah.
Why?
Well, I think it's, first of all, if you think in your own life, when you get mailings from insurance companies, they're often confusing. And a lot of people, the tendency is, like if you have a job and you have employment through your job, if you do nothing, you just, your insurance is renewed every year. And so I think a lot of people, it's not just people on Medi-Cal and Medicare, it's confusing no matter how easy you make something to understand these programs. I think it's also, I could go into more detail about, people were also enrolled in a Part D plan, which is the plan for drugs under Medicare, and that has to change too. So when people got these letters about that they have to change their Part D plan, they got very scared. And so I think that is, the state and the federal government are working, I believe, on improving that as this rolls out. But they've been learning, the state has been learning throughout this process and trying to make it simpler and better.
So this is a trial program? It lasts for what, 3 years or?
So this is being described as a demonstration, and it's being rolled out in 7 counties first. It is a 3-year demonstration, and there are quality metrics that go along with each year of the program. So the state will be collecting information about how health outcomes change as more people enroll and as their care progresses through those 3 years.
So I received one of these blue package, and again, it's very confusing, even in my native language too. Now, how are you going to be sure that those underserved communities, those folks, will have that knowledge about those benefits that's going to be offered to Connect?
Before you answer, what was confusing about it?
Confusing is the language, and I had no idea. Up until this day, after I heard from you the difference between Medicare Part A, Part B, and Part D. I don't know what are these things all about. Every time when I take my father and my mother-in-law to the doctor, I give all three of them to the doctor, and they'll take whatever they want because it's confused me. I don't know what Part A and Part B and Part D does.
So would it make sense when people get that packet and those letters, they call for information? Maya, you said someone can walk them through it and explain.
Yes, I think that's the best.
Does it have your number on those packets?
So,
your health plan?
you know, the rollout varies by county. So in San Mateo County, the health plan actually sent out all the notices. We got them approved by the state and the federal government, but we sent them out, and it has our number on there. And we have people who speak Tagalog, who speak, both Mandarin and Cantonese. We have people who speak Russian. And so we'll hook people up with their own language so that we can explain it to them in their own language.
You said 30% of the people opted out.
Yes.
Do you know how many were eligible?
How many people? There were about 4,200 people that were eligible at that point.
And do you know, and can you say when it started in San Mateo County?
It started on April 1st in San Mateo County of this year.
Okay, and what has been the experience thus far?
The experience has been good. I mean, we have been busy doing the health risk assessments that Shelly described, and we've had a good response. We haven't been able to reach everybody, but we've reached a good number of people, especially the people who are high risk. And we're connecting people up to services. We're starting a program to try to help people move out of nursing homes who want to move out of nursing homes. We're working together with the county social workers that run the in-home supportive services. So I think we're very excited about the program and the benefits it can offer our members.
Have you had a chance to connect with any of the 30% who opted out to ask them why?
No, we haven't. But we've had another program for people who are dually eligible, a more limited program called a special needs plan for many years. And we've been marketing that program to many of these same people. So I think many of these people, they decided, this long time ago, this isn't for me. And, not everybody wants to be in a program like this. Or not everybody needs to be in a program like this. I mean, if you're fairly healthy and you're doing fine, you might not be interested. And as I said, some of the people see doctors at UCSF, for example, who do not contract with us, and it makes it much more complicated for them to be in a program like this.
So, Tony, Santa Clara hasn't started yet.
Correct.
Santa Clara will start when?
January 1st.
And do you talk with those who are administering the program in San Mateo County?
Yes,
in terms of what they're doing, and have you made any changes based on maybe their experiences?
We have ongoing conversations with San Mateo and a couple of other plans. So we are certainly trying to learn from all of their experiences. So it's it's a little different in Santa Clara in terms of the enrollment because the state has a third party called Healthcare Options, which the members call to disenroll or to enroll if they choose to do so voluntarily. So it seems like there's a lot of things going on, and there are, and so that creates a little bit of the angst is that there is change. But the good part of that is that there are options. When Medicare was simply the fee-for-service program, it was simpler in a sense to understand because you didn't have to choose amongst all the options. But there are some very good programs that do work for people that are in a more structured setting, or like this program coming in new that will do some things that are unique and combining multiple different programs. So in the end, it will be simpler for some people.
Okay, can you, you just now said some things that are unique. Can you maybe talk about some of the unique benefits that people might get when it rolls out in Santa Clara County?
Okay, so in terms of the specific benefit, transportation is often one of those that is available in a little more flexible structure in the benefits package. But I think something that Shelly was talking about earlier too is it's this care coordination, this interdisciplinary care team that gives either the patient, the member, or their family members an advocate who helps them through what's, a part of what makes this complex is that when people are ill and need care, there are so many different things that are going on and so many different places to try to figure out where to get that care. And I think that's really a big benefit of this program, is to have that coordinator who's there to help you navigate through that. So, there are choices that seem a little overwhelming because of the number of options that are available, but that benefit of having someone who will help guide you through what's going on in terms of particular episodes of care and things that, benefits or providers that are needed is a real advantage.
That